Hi, I'm Rui Pereira da Costa, organizer of the International Endomasters 2015. I feel very happy for having my friend and colleague Javier Pascual from Spain presenting in this World Online Congress of Endodontics. Javier graduated in dentistry at the Universidad Europea in Madrid, and he completed his master's degree in endodontics at the International University of Catalonia in Barcelona. After his master in endodontics, Javier did a one-year clinical residency in periodontic at the International University of Catalonia in Barcelona, so he is an expert in both areas. I guess Javier is the perfect choice to speak about the topic of this next lecture, the relationship of endodontic and periodontic lesions that always represent a diagnostic puzzle and a treatment challenge. Not to be missed. See you soon!
Hello everybody, I'm really glad and proud of being part of this first International Endomasters Online Congress. Today I'm going to talk about the relationship of endodontic and periodontal lesions. There are many factors that contribute to the development and progression of endodontic and periodontal diseases. The primary cause of both diseases is the presence of bacterial infections. It is widely accepted that an untreated infection of one of these tissues can lead to signs and symptoms of disease within the other tissue. Once both the pulp and the periodontal tissues have become involved, the diagnosis and management of the situation become more complex and will require extra considerations. Traditional approaches to assessing and managing teeth with concurrent endodontic and periodontal diseases have been somewhat confusing as a result of inconsistent, inaccurate, and confusing terminology. The aim of this lecture is to provide a rational approach to managing teeth with endodontic lesions that mimic periodontal lesions, periodontal lesions that mimic endodontic lesions, and finally teeth with concurrent endodontic and periodontal diseases at the same time. The quality guidelines of the European Society of Endodontology in 2006 describes endodontics as the specialty that studies the form, function, the health of, injuries to, and the diseases of the pulp and the periradicular region. Endodontic treatment encompasses procedures that are designed to maintain the health of all or part of the pulp. Here you can see an MTA direct pulp capping in a complicated crown fracture due to a dental trauma. 3-year recall shows that this partial pulp treatment allows the normal root development. But when the tooth pulp becomes infected and necrotic by autogenous oral microflora, the microbial invaders in the root canal advance and or their byproducts egress from the main and accessory foramens to the periapex. So then, the host mounts an array of defense. The microbial factors and the host defense forces encounter, clash with, and destroy much of the periapical tissues, resulting in the formation of various categories of apical periodontitis lesions. In certain degree, endodontics is a form of periodontal treatment. Periodontists treat the attachment apparatus at its margin, and endodontists treat the attachment apparatus in the periapical area. A 12-year-old girl was referred with symptoms compatible with an acute periradicular abscess associated to a pulp necrosis. Tooth show a class 3 mobility, a fluctuant swelling around the buccal gingiva mucosa, and purulent drainage through the sulcus. Mind the huge decay, lesion, and the radiolution areas in the furcation and the periapical area. Root canal treatment was completed in 2 appointments with a calcium hydroxide medication for 2 weeks. At the time of the definitive canal obturation, patient was asymptomatic, and tooth show mobility and province within normal limits. In the 6 months recall on your right, you can see periapical and furcal radiolution lesions resolution and a normal PDL space around the roots. Periodontitis is defined as an inflammatory disease of the supporting tissues of the teeth caused by specific microorganisms or groups of specific microorganisms, resulting in progressive destruction of periodontal ligament and alveolar bone with pocket formation, recession, or both. The clinical feature that distinguishes periodontitis from gingivitis is the presence of clinically detectable attachment loss. Radiographically, periodontitis is associated with patterns of horizontal or vertical bone loss. The periodontium consists of those tissues that surround and anchor the tooth in the maxillary and alveolar process. These tissues include the gingiva and the gingival attachment to the tooth, formed by the cementum, the periodontal ligament, and the alveolar bone. The attachment apparatus can be affected by three different diseases: endodontic, periodontal, or occlusal origin. These different pathologic processes may also coexist in the attachment apparatus of the same tooth, giving rise to the so-called combined lesions. There is a reciprocal relationship between endodontic and periodontal pathologic processes. The two diseases may have many signs and symptoms in common, causing great diagnostic difficulties which become even greater when the two pathological processes coexist or when one simulates the clinical or radiographic appearance of the other. Communications between the dental pulp and the periodontal tissues. Tissues from the dental pulp and the periodontium are interlinked from the embryonic stage. The dental papilla, precursor of the dental pulp, and the dental sac, precursor of the periodontal ligament, are of common mesodermal origin. At the late veil stage, epithelial root sheath separates the dental papilla and the dental follicle. The embryonic development gives rise to the anatomical connections which remain throughout the life of the tooth. Communications between the dental pulp and the periodontal tissues can be divided into two main categories: anatomical physiological communications and pathological communications. Three are the anatomical communications between the pulp and the periodontium. First, the apical foramen, which is the principal and most direct route of communication between the pulp and the periodontium. It is the principal two-way window by which the two pathologies may spread. Second, accessory foraminas from lateral furcal and accessory canals. They may be present anywhere along the root surface. This aberrant anatomy contains connective tissue and vessels that connect the circulatory system of the pulp with that of the periodontium. Main and accessory foramens are necessary for vascular, lymphatic, neural, and connective tissue communications. Third, dentinal tubules. They run from the pulp to the dentinoenamel and dentinocemental junctions. Normally, dentinal tubules do not communicate with the periodontium because of the interposition of the radicular cementum. Loss of cementum because periodontal disease or treatment or root resorption represents a communication between pulp and periodontium through the tubules. The anatomical communications are subject to several dynamic changes from early root formation and passing through different physiological exchange mechanisms. With age, the apical foramen decreases in diameter and changes its deviation from the root long axis is increased because of cementum apposition. With age, the accessory canals gradually decrease in number, and with age, the radicular dentin becomes less permeable because of the formation of sclerotic dentin. Pathological communications. The pulp and the periodontal tissues may communicate through either direct pathological pathways such as a perforation or a root fracture, or indirect such as a deep radicular groove. Pathological communications can be divided into developmental and non-developmental communications. Developmental anomalies include palatogingival grooves, typically seen in lateral incisors, cementum line radicular invaginations, enamel pearls, accessory distolingual roots. These anomalies are associated with plaque retention and subsequent periodontal disease in areas showing high incidence of accessory root canals. Non-developmental factors are either related to disease like root caries or external root resorption due to infection, related to trauma like trauma-induced root resorption, for example in an avulsion or a luxation injuries, and related to iatrogenic events which include root fracture after endodontic treatment, perforations, or exposed to dentinal tubules after scaling and root planing. The periodontal endodontic controversy. There is a controversy related to the effect of periodontal disease on the dental pulp and the effect of pulp necrosis on the initiation and progression of marginal bone loss. The main questions are: is periodontal disease a cause of pulp necrosis? And can a pulpless tooth be the cause of periodontal disease? Let's see. Effects of the periodontal disease on the dental pulp. Histological and clinical studies suggest that a pulp necrosis secondary to periodontal disease is rare. The periodontal disease must extend all the way to the apex of a tooth before an accumulation of plaque in the apical foramen and foramina can cause significant pulp involvement. Pulpal insults through patent dentinal tubules and exposed lateral canals have relatively insignificant effects on the ability of the dental pulp to survive. Sarnecki and Schindler performed an histological study of intact, caries-free teeth and compared the pulps of teeth which were periodontally within normal limits and with teeth which had periodontal disease. The pulps in the intact, caries-free periodontitis group were all significantly within normal limits regardless of the severity of the periodontal disease. Bergenholz and Niemann evaluated 52 patients with advanced periodontal disease over a 4 to 13 year period. Of the 417 non-abutment teeth, 60% had crestal bone level in the apical 2/3 of the root. Only 3%, 14 cases, required root canal treatment. From these 14 teeth, only 4 authors pointed out that necrosis could be related to the progression of periodontal disease involving the root apice. Here you can see a patient with a generalized advanced chronic periodontitis. All these teeth presented with a class 3 mobility and provings up to 10 mm in more than one point. Radiographically, it can be identified that bone loss has reached the apical third of the roots of all incisors. Central and lateral incisor tested positive and within normal limits to cold. Effects of periodontal treatment on the dental pulp. From clinical research studies in the periodontics literature, it appears that a periodontal treatment as well as periodontal disease has a negligible effect on the dental pulp. Whatever can cause the sectioning of a lateral or an apical blood vessel, like a dental trauma or an scaling and root planning procedure, leads to loss of blood supply to the pulp with a consequent ischemic necrosis and later pulp death. But combining results from clinical studies from Ross and Thompson, Bergenholz and Niemann, and Hawoyi in patients with advanced periodontal disease who received appropriate periodontal treatment and maintenance for periods ranging from 4 to 24 years, less than 5% of the teeth developed pulp necrosis, and most of the time it was related to recurrent decay. Periodontal treatment may lead to the need for endodontic treatment when it is necessary to perform hemisection, root amputation, or bicuspidization in a periodontally diseased tooth with a vital pulp. In these situations, endo treatment is mandatory before the periodontal resective surgery. In conclusion, if the pulp becomes affected as a result of periodontal treatment, endodontic treatment must be undertaken as soon as possible so as not to contribute to the disease of the attachment apparatus of the tooth. Effects of endodontic disease on the periodontal tissues. A tooth with a necrotic pulp or root canal treatment should not be considered as a risk factor for initiation of periodontal disease, progression of periodontal disease, and resolution of periodontal pockets. Some studies, like the series from Jansson, Ennevitt, Linskog, and Blomshoff, suggest that endodontic disease is associated with deeper probing depths, more bone loss, impaired periodontal healing following periodontal treatment, and enhanced progression of periodontal disease. In reality, these associations seem not to be true. Classic studies about periodontal prognosis from McGuire show that endodontic involvement at the time of periodontal treatment plan is not a significant clinical factor associated with tooth loss. Miyashita used a pair sampler in which the test tooth had been endodontically treated or not treated but had a periapical radiolucency but not the control tooth, selected patient had minor or no signs of periodontal disease. Larger loss of alveolar bone support was found in test teeth versus the control tooth, but the difference was not statistically significant. The study failed to show a correlation between a reduced marginal bone support and endodontic status. It is of interest to note that 61% of the root canal fillings were judged inadequate at the cervical third of the canal. Niemann and Linde compared for a 5 to 8 years period bone height measurements in vital and endodontically treated teeth. They found that the bone height was maintained equally well around the vital and the root canal treated teeth. Effects of the endodontic treatment on the periodontal tissues. As we will see later, destruction of the periradicular periodontium may also occur in the course of common procedures of endodontic therapy. For example, the use of very strong medications such as arsenic or paraformaldehyde-based devitalizing paste is very dangerous. It can lead to serious injury to the PDL and bony sequestrations. But the most serious periodontal destructions occur in case of perforation or root fractures. A patient was referred for endodontic retreatment of tooth 3.7. Patient referred a previous history of endodontic treatment 2 years ago and an attempt of endodontic retreatment in referral practice 3 weeks ago. At the time of consultation, patient referred a slight sensitivity when biting and palpation. Tooth presented with a normal mobility, a narrow deep probing up to 12 mm in buccal central, a class 2 buccal focal lesion, and a sinus tract in the buccal attached gingiva. Radiographically, tooth show a huge radiolution area compromising the whole root length, a slightly radiopaque material compatible with a perforating fiber post. An asymptomatic periradicular abscess was diagnosed. The long history of this pathological endoperio communication resulted in a massive periodontal breakdown. After discussion with the patient and considering the poor prognosis, tooth was immediately extracted. Vertical root fractures seems to be a very common reason for extraction of endodontically treated teeth, currently more frequent than in the past. When a vertical root fracture occurs, it extends to the periodontal ligament, whereupon soft tissue grows into the fracture space and increases the separation of the root segments. On communication with the oral cavity through the gingival sulcus, food debris and bacteria obtain access to the fracture area and an inflammatory process is induced in the periodontal tissues, resulting in periodontal ligament breakdown, alveolar bone loss, and granulation tissue formation. In this case, you can see an endodontically treated molar. Radiographic exploration shows excessive coronal flare and increased radiolution space of the PDL in the coronal third of the mesial root. Probing under anesthesia reveals a localized deep and narrow defect in the mesolingual aspect. An exploratory surgery was performed confirming the presence of a vertical root fracture in the mesial root. Clinical diagnostic procedures in the diagnosis of endoperio lesions. A thorough analysis of the information obtained from the medical and dental history and the objective information obtained from the clinical and radiological examination are crucial to achieve a proper diagnosis. One test is usually not sufficient to obtain a conclusive diagnosis. Clinical exploration includes a visual examination of soft tissues and hard tissues. Presence or absence of periodontal disease often can be determined in seconds by looking for signs of gingival inflammation. Color, shape, and texture are three important parameters to evaluate. Healthy gingiva is described to be staple, coral pink, tightly adapted to the underlying tissues and with a scalloped edge configuration. The gingival margin is located at the cemento enamel junction. Inflamed tissues usually present redness, especially near the gingival margin, swelling and changes in normal size, shape, and form. Normally, periodontal diseases are generalized processes, an endodontic disease's localized process. An endodontic infection draining through a periodontal pocket mimic a periodontal abscess. Clinical exploration, assessment of the periodontal damage. Assessment of the periodontal damage with a calibrated periodontal proof includes the proving depth, the gingival margin position, and the clinical attachment level. These parameters are recorded at 6 sites around each tooth. Proving depth reflects the distance from the gingival margin to the base of the probable crevice. It is important because it gives a good approximation of the principal habitat of the periodontal pathogens. In order to establish the amount of periodontal damage, the clinical attachment level is determined. The clinical attachment level is the distance between a coronal stable landmark, the cemental enamel junction, for example, and the base of the probable crevice. Periodontal proving is an important test that should always be performed when attempting to differentiate between endodontic and periodontal disease. A periodontal proof introduced in a periodontal lesion usually reveals white defects that do not extend to the apex of the involved roots. These white defects usually are also seen in other teeth of the mouth. A periodontal proof introduced in an endodontic lesion usually reveals a very narrow and deep defect extending as far as the apex or the emergence of a lateral canal. This kind of defect is normally localized in the offended tooth. Of course, there are some situations where these rules cannot be applied, like periodontal lesions associated with a local factor. Clinical exploration of hard tissues. In the clinical exploration, teeth need also to be carefully inspected for plaque and calculus, dental caries, cracks, or fractures, restorative problems such as leaking or overhanging restorations, and developmental defects such as groove or areas of denuded dentin at the cemento enamel junction. The magnification and illumination provided by the dental microscope is of great help in this search. Presence of caries, fissures, and big coronal restorations could be associated with endodontic diseases. A virgin tooth, presence of calculus, and overhanging restoration or radicular grooves could be associated with periodontal lesions. Local factors. In clinical exploration, it is very important to be aware of presence of local factors. A local factor is defined as anything that influences the periodontal health status at a particular site or sites with no known systemic effects. These may be anomalies in the root anatomy or iatrogenic features. They are not etiologic factors, but tend to increase the progression of periodontal disease in presence of etiologic factors in a particular site. Local contributing factors can be classified as anatomic, restorative, orthodontics, and habits. Common anatomic factors are narrow furcation entrance, root proximities, deep root concavities, palatal grooves, cervical enamel projections. Restorative factors such as open contact margins, overhanging dental restorations, over-contour crowns, subgingival margins. Orthodontic factors are mainly crowding and malocclusions, and habits such as aggressive toothbrush or floss, mouth breathing. Clinical exploration. Pulp vitality testing. Pulp vitality tests are designed to assess the response of the pulp to different stimuli. An abnormal response may indicate degenerative changes in the pulp. In general, no responses indicates pulp necrosis. Moderate transient response indicates normal vital pulp. Quickly painful response may often indicate reversible pulpitis, and lingering painful response indicate irreversible pulpitis. In a primary endodontic lesion, the pulp without doubt and without exception is necrotic. Vitality tests are negative. In primary periodontal lesions, the pulp stays healthy, so the response to thermal, electric, and cavity test is within normal limits. The most commonly used pulp vitality tests are thermal test and cavity test. Cavity test, although is highly reliable in determining the vitality of the pulp, should only be limited to cases where all other tests prove inconclusive and definitive diagnosis of the pulp condition could not be established. Thermal tests are designed to reproduce patient symptoms and thus reproduce their pain. One must first have the patient experience the response of a normal pulp before proceeding to test the suspected tooth or teeth. Teeth must be dry and isolated with cotton rolls, and the hot or the cold stimuli should be applied in the cervical area, where the enamel is thinnest. A single tooth isolation with rubber dam and bath of the tooth with cold or hot water can be another valid option for this test. Lack of response to this test may suggest either a necrotic pulp or a false positive response due to excessive calcification, an immature apex, recent history of trauma, or patient premedication. Radiological exploration. No radiograph should be exposed on a patient without performing a thorough clinical examination first to determine how many images and what type of images are necessary in a patient. An adequate periodontal and endodontic examination will most often require both bite wings and periapical radiographs. Radiographs must be taken with a paralleling device in order to achieve accurate estimations of bone level and root anatomy. Bite wings are essential in endodontic and periodontal diagnosis. Bite wings are taken during radiographical periodontal examination in order to assess the alveolar bone height, the distance from enamel cemental junction to the alveolar bone crest, the interdental septum, the presence of crestal lamina dura, pattern of bone loss, and furcation area. Depending on the grade of severity of the periodontal disease, horizontal or vertical bite wings should be taken. Bite wings are taken during radiographical endodontic examination in order to get more precise and less distorted information about the condition of the pulp chamber. Deep caries, deep fillings, pulp cappings, pulpotomies, calcifications can be evaluated better with bite wings. Periapicals. Periapical radiographs are also essential in endodontic and periapical diagnosis. Periapicals are taken during radiographical periodontal examinations in order to assess the periodontal ligament space, the interdental septum and crestal lamina dura, pattern and percentage of bone loss, crown-root ratio, radicular form, root trunk, furcation area, radicular proximities, presence of calculus, status of previous restorations. Periapicals are taken during radiographical endodontic examinations in order to assess root curvatures, root length, root development, pulp space width, periodontal ligament, periapical and lateral radiolucencies, evidence of prior endodontic treatment, fistula tracking, root resorptions, canal calcifications, previous endodontic treatments. A thorough analysis of all of these parameters is crucial in order to achieve a proper diagnosis. In general, periodontal lesions are often manifested by angular bony luces, beginning with the cervical region directed apically, and they are generalized to the various sectors of the mouth. Endodontic lesions, in contrast, present with destruction of the apical periodontium, occasionally extending coronally and normally presented in a single tooth. Endodontic lesion. These two periapicals represent the typical radiographic presentation of a lesion of endodontic origin. Disease is only localized in one tooth. There is a portal of entry for bacteria to the pulp space through an extensive liquid restoration. There is no crestal bone loss but a periapical radiolucency, and fistula tracks to the apical area. Periodontic lesion. These two periapicals represent the typical radiographic presentation of a lesion of periodontal origin. Disease is compromising more than one tooth. There is no decay nor fillings associated with the tooth. There is crestal bone loss with no periapical lesion, and fistula tracks to the middle third of the roots. This table from Abbott 2009 paper in Australian Dental Journal summarizes the common clinical and radiographic findings when examining a patient for endodontic and periodontal diseases. In pulp periapical lesions, disease is localized in just one tooth. Normally, there is a presence of extensive caries or restoration. Pulp responds negative to sensibility test. There is no crestal bone loss evidence on radiographs, but there is a radiolucent area present in the apical third. In periodontal lesions, normally disease involves more than one tooth. There is not extensive caries or restorations, and very important, pulp responds positive to sensibility test. Radiographically, as we have explained before, there is evidence of crestal bone loss and there is not a periapical lesion. In concurrent endodontic and periodontal lesions, disease normally is localized to one tooth, but it can also be affected more than one tooth if patient has generalized marginal periodontal disease. Tooth affected normally shows extensive decay or restoration, and there is a negative response in sensibility test. Radiograph shows deep white-based pocket due to the periodontal disease process, and there is also a periapical lesion. So, next point to review is the classification of endoperio lesions. A review of the literature identifies many suggested classifications for endoperio lesions. Most of these classifications are based on either etiological factor, pathological patterns, or treatment strategies and prognosis. The considerable variability in etiological factor and pathological patterns of endoperio lesions are not yet corresponded with a satisfactory evidence-based classification that can precisely place endoperio lesions in a clear and accurate categories. Wayne proposed a classification based on treatment needs rather than on the diagnosis of the problem. This classification is not useful since the disease should be diagnosed before considering a treatment approach. Guldener classification is based on both the cause of the disease and the treatment needs. It is a complex classification that involves problems and conditions such as groove, resorption, perforation, root fractures. This problem can involve the pulp and the periodontal tissues, but they are not strictly combined or concurrent endodontic and periodontal diseases. The most popular classification of endoperio lesions was formulated in 1972 by Simon, Frank, and Glick. This classification is based on the possible etiology, diagnosis, and prognosis of treatment. The classification includes 5 categories. On the top, you can see the pure lesions. Pure lesions can be divided into 2, primary endodontic disease and primary periodontal disease. They are not combined lesions in reality. The combined diseases include 3 categories: the primary endodontic disease with a secondary periodontal disease, the primary periodontal disease with secondary endodontic disease, and the true combined diseases. Main problem with this classification is that many times it is not possible to distinguish the combined secondary diseases from the true combined diseases. This is because it is not possible to determine which tissue was the first one to be affected. Class 1. The primary endodontic lesion. It is a drainage arising from acute or chronic lesions of endodontic origin. They occur along the root surface and open through the gingival sulcus, simulating a periodontal abscess. Infection can arise from the apex or from a lateral canal situated at any level of the root. This is not a periodontal pocket, but a simple fistula, which rather than opening in the buccal or lingual mucosa, has opened in the gingival sulcus. Drainage through the gingival can follow 2 pathways. The path courses through the fibers of the periodontal ligament. In this situation, it is possible to prove a very narrow and deep defect. or the pus originated in the apical area, perforates the cortical bone near the apex and runs between the periosteum and the alveolar bone, and finally opens in the gingival sulcus. This extraosseous fistulization cannot be proved because the PDL and the bone are not affected. In the endolesions, fibers of the PDL are disarrayed, disorganized, and become afunctional, but are not destroyed as happen as a consequence of periodontal disease. This endodontic lesion never causes changes in the connective tissue fibers that insert in the bone or cementum. Here are summarized some of the main clinical characteristics of the class 1 lesions. Normally, only one tooth is affected. Pain. Although endodontic lesions are usually associated with sharp pain, in this type of lesions, normally pain is not present because it is a chronic lesion with an open drainage. Only pain may be present if this drainage is closed. As this is pulp disease, sometimes a previous whole history of pain compatible with pulpitis could be associated. Soft tissue exploration normally reflects a localized swelling in the attached gingiva and or a drainage from the gingival sulcus. Adjacent teeth normally can show a normal periodontal condition. Tooth normally shows deep caries, huge defective restoration, crack lines, or discolorations. These correspond to the portal of entrance of bacteria to the pulp tissue. Very important, there is a negative response to thermal, electric, or to the cavity test. Periodontal proving usually reveals a very deep and narrow proving on one point. As we have seen in the last slide, there is a normal proving when drainage has been established between the periosteum and the bone. Here are summarized some of the main radiological characteristics of the class 1 lesions. As you can see in the first radiograph, different levels of bone loss may be apparent depending on the avenues of fistulization. When a sinus tract runs from the apex through the periodontium along the mesial or distal root surface to exit at the cervical line, this appears as a radiolucency along the root length. It is not a totally dark radiolucent area, instead a grayish with a bony matrix visible. In the second radiograph, you can see a radiolucent area in the furcation with normal crestal bone levels in the mesial and distal aspect. It is also typical in this type of lesions. If the lesion is related to a lateral canal, some distance from the apex on the mesial or distal aspect, lesion could be confused with an infrabony pocket. Involved tooth usually presents deep restoration or decay compromising the pulp chamber. Normally, bone levels in adjacent tooth are within normal limits or do not show such advanced lesions. Treatment and prognosis of class 1 lesions. Once the diagnosis has been made, it is necessary to treat quickly in order to prevent the development of a secondary periodontal lesion. Primary endodontic lesions have a favorable prognosis, and one can therefore expect complete healing after endodontic therapy. Periodontal treatment is not needed. As these cases are sometimes related to intracanal infection associated with lateral canals, one should keep in mind that these areas of the pulp canal system cannot be shaped, cleaned, or sealed as good as the main canal. Persistent intracanal infection associated with lateral canals have been described as a cause of endodontic failure, but in general it is considered that the prognosis of this type of lesions is good. Here is a case of a class 1, a primary endodontic lesion. This patient was referred to my practice by the oral surgeon for endodontic treatment of tooth 4.2, 4.1, 3.1, and endodontic retreatment of tooth 3.2 before a cystectomy surgery. Patient referred history of pain compatible with an acute periapical abscess about 2 weeks ago. Patient had been treated with antibiotics in the last 10 days and at the time of consultation was asymptomatic. Tooth 3.2 was endodontically treated about 25 years ago. Patient cannot remember previous history of dental trauma and periodontal treatments. Clinical exploration showed a general healthy periodontal condition. Teeth 4.2, 4.1 and 3.1 tested positive and within normal limits to cold test. Teeth 3.2 show a deep narrow pocket at up to 10 mm in the distobuccal aspect with intense bleeding improving. Radiographic exploration show a huge periapical radiolucency around the lower incisors. In the coronal and the middle third on the distal aspect of tooth 3.2, there was a grayish radiolucent area. Note how there is a bone matrix visible on it. Radiographic exploration also show a previous poor endodontic treatment. Based on all this information, a diagnosis of a chronic periapical abscess was established. So, non-surgical root canal retreatment of tooth 3.2 was done in multiple visits with a calcium hydroxide medication. 8 weeks after initiation of treatment and at the time of the definitive root canal obturation, there was normal proving all around the tooth, and the lateral radiolucency had healed and showed a normal PDL space. The last two radiographs is a 6-month recall reevaluation. Only endodontic retreatment had been carried out. Patient was asymptomatic, periodontal condition was within normal limits, and periapical radiolucency is decreasing in size. Here is another classical presentation of the class 1 primary endodontic lesion. This patient was referred to my practice, and at the time of exploration, patient was symptomatic. Tooth showed a large amalgam leaking restoration. There was a fluctuant swelling in the buccal gingiva, and teeth did not respond to cold test. There was a deep and narrow proving of up to 10 mm in the buccal furcation area and a class 2 horizontal defect. Periapical radiographs were taken and it showed a leaking restoration close to the pull chamber, no crestal bone loss, and a radiolucent area in the furcation. A diagnosis of necrotic pulp with an asymptomatic periradicular abscess was identified. Non-surgical root canal treatment of tooth 4.2 was done in 2 appointments with a calcium hydroxide medication. Note, in the second radiograph, the obturation of a lateral canal in the distal root canal system with the canal medication. After 4 weeks, patient was asymptomatic, there was normal proving in the furcation area, and so root canal system was definitely obturated and patient was referred with the colleague for the coronal restoration. Here's an 18-month reevaluation of the case. Remember, this is a class 1, a primary endodontic lesion, and only endodontic treatment had been carried out. Patient at 18 months was symptomatic. Periodontal condition, as you can see in the picture, is within normal limits, and in the periapical you can see that the periapical and the furcal radiolucency are healed. Class 2, the primary endodontic lesion with a secondary periodontic involvement. In reality, it is a primary endodontic lesion untreated for a long period of time. If after a period of time a suppurating primary endodontic disease remains untreated, it may become secondarily involved with periodontal breakdown. Plaques form at the gingival margin of a sinus tract and leads to a localized plaque-induced periodontitis. Other common clinical situation described as compatible with class 2 lesion is a vertical root fracture in an endodontically treated teeth or a root perforation. Clinical presentation of class 2 lesions. From a practical point of view, this lesion may not be distinguishable from a class 1 lesion. The persistence of proving 15 days after endodontic treatment could suggest a posteriori the diagnosis of a class 2 lesion and the need also of periodontal treatment. Clinical characteristics of the class 2 lesions are similar to those of the class 1 lesions. Presence of calculus could be the main difference. Here is a case of a class 2 lesion treated by endo and perio students from Universitat Internacional de Catalunya. This patient presented with signs and symptoms compatible with an asymptomatic periapical abscess. Clinical exploration showed a healthy periodontal condition, but a localized 10 mm proving in the buccal furcation area of tooth 3.6. Radiographic exploration showed a previously underfilled and underextended endodontic treatment with a radiolucent lesion in the apical and the furcation area. Note, mesial and distal crestal bone levels are preserved. Root canal retreatment was completed, and 4 weeks after endodontic retreatment, an increased proving in the buccal furcation area was still present. After a consultation with periodontics department, it was decided to perform periodontal treatment. Surgical access revealed the presence of calculus attached to the furcation entrance. Here is the 6 months recall of the case. Patient is asymptomatic. Radiographically, periapical and furcation lesions are decreasing in size. Clinically, you can see a recession of 3 mm and a pocket of 2 mm and absence of bleeding on proving. The third category is the primary periodontal lesion. Lesion is caused by periodontal disease. In this process, periodontitis progresses apically along the root surface beyond the radicular apex. Clinicians must be aware of presence of periodontal locus factors, as we explained before. Here are summarized some of the main clinical characteristics of the class 3 lesions. Normally, the periodontal disease process is advanced and generalized. An exception could be a lesion related to a periodontal local factor. We will see a clinical case in the next slides. Normally, it is an asymptomatic process, but can present as an acute periodontal abscess with pain also. Soft tissue normally reflects generalized signs of periodontal disease, such as recession, swelling, provings. Calculus is normally present and congruent with the amount of periodontal destruction. Tooth normally shows no caries or minimal restoration. Local factors such as grooves, enamel cervical projections, overhanging restoration or crowding may be present. Pulp tests are very important. As there is no pulp infection, there is a positive response to thermal, electric, and cavity tests. Periodontal proving usually reveals multiple points of wide and conical defects. When a local factor is present, a deep narrow defect can also be observed. Radiological presentation of class 3 lesions. X-ray explorations usually shows a generalized vertical and horizontal bone loss along the root surfaces at various levels. There are usually multiple teeth with periodontal disease involved, rather than just a single tooth. Defect is displayed as a V shape, wide open at the corona, and the apical area is seldom affected. In case of heavy calculus deposits, they can be seen on radiographs. Treatment and prognosis in class 3 lesions. Only periodontal treatment is needed. Endodontic treatment is not necessary as pulp is not affected. Treatment should be applied as soon as the diagnosis has been reached, in order to avoid a secondary endo lesion. Prognosis in these cases depends on the severity of the periodontal disease and the patient response to periodontal treatment. Advanced techniques of periodontal regeneration can considerably improve the prognosis of these teeth. Here is a case of a class 3 lesion treated by Dr. Abella from Barcelona. Patient presented with a deep and narrow localized pocket in the central buccal of tooth 4.6. Horizontal proving revealed a class 2 defect in the buccal furca. There was an occlusal amalgam film and a positive normal response to cold test. Radiographic periapical shows presence of interproximal calculus, an apparent intact pull chamber not associated with deep fillings or decay. Interproximal crestal bone levels are preserved, but there is a radiolucent lesion in the furcation area. Based on this data, a class 3 lesion was suspected and periodontal therapy was performed. Surgical access revealed the presence of an enamel cervical projection in the entrance of the buccal furca. Elimination of the enamel cervical projection, debridement, and tissue regeneration procedures were performed. Endodontic treatment was not necessary in this case. As we have said, in class 3 lesion there is no pulp involvement. This is another case of a class 3 lesion treated by Dr. Platón from Palma de Mallorca. Patient was diagnosed with a generalized advanced chronic periodontal disease. Tooth 1.1 tested positive to cold test and revealed the presence of a deep proximal pocket of up to 10 mm in the mesial aspect. Radiographic examination showed a pattern of horizontal and vertical bone loss with an infrabony lesion. After evaluation of phase 1 periodontal therapy, a regenerative surgery was performed. Debridement, application of endogame and ceramic bone from Straumann, and a coverage with a membrane was performed. And this is the 3-month reevaluation of the regenerative surgery. Remember, no endodontic therapy is needed in this type of cases, as there is no pulp involvement. Class 4. The primary periodontal lesion with a secondary endodontic involvement. The apical progression of a periodontal pocket may continue until the apical tissues are involved. In this case, the pulp may become necrotic as a result of the infection entering via the apical foramen and lateral canals. Treatment of periodontal disease can also lead to a secondary periodontal involvement. Lateral canals and dentinal tubules may be opened to the oral environment by scaling and root planing procedures. Root amputation provoke a pulp exposure to the oral cavity too. Clinical presentation of class 4 lesions. The characteristics of the class 4 lesions are pretty similar to the class 2 lesions. The main difference is that in class 4 lesions, as there is also pulp disease established, there is a negative response to thermal, electric or cavity test. Clinically and radiographically, huge apicomarginal defects can be appreciated. This is a case of a class 4 lesion treated by Dra. Garcia from Barcelona. This patient presents with a generalized advanced periodontal disease. Tooth 1.2 has a negative response to cold test and presents with deep pockets of up to 10 mm. Radiographic examination reveals a pattern of vertical bone loss and calculus. There is an intact crown, no caries, no filling, no grooves, and patient does not refer previous history of dental trauma. Based on all this information, a diagnosis of a pulp necrosis secondary to an advanced periodontal disease was done. After endodontic treatment and reevaluation of phase 1 periodontal therapy, a regenerative endodontic surgery was performed with endogame. And here is the clinical and radiological aspect 2 months after treatment. First, endo and then periodontal treatment is needed in this type of lesions. And finally, the class 5, the true combined lesion. True combined endodontic and periodontic lesions occur when the 2 independent diseases coexist in the same tooth. Picture on the right represents a true combined lesion. Periodontal and endodontic lesion have a communication along the root. On the other hand, picture in the left shows a molar with a perio and an endo lesion of different origin, but note they are not merging. This is not really a true combined lesion. Clinical presentation of class 5 lesions. Here are summarized some of the main clinical characteristics of these lesions. Normally, there is a generalized advanced periodontal disease. Pain is not present, but there could be an acute phase of endo or perio origin. Soft tissues exploration normally reflect a localized swelling in detached gingiva and oral drainage from the gingival sulcus. Adjacent teeth normally show signs of periodontal disease. Tooth normally shows deep caries, huge defective restoration, crack lines or discoloration, which correspond to the portal of entrance of the bacteria to the pulp tissue. There is a negative response to thermal, electric and cavity test. Sometimes this test can be inconclusive in multiradicular teeth. Periodontal proving usually reveals generalized medium-deep pockets around the teeth and in one point at the base of the periodontal defect a communicating deep and narrow tubular defect of endo origin. Radiological presentation of class 5 lesions. Normally, there is a generalized pattern of vertical and horizontal bone loss, with a radiolution area all along the root surface and the periapical tissues. Involved tooth usually presents deep restoration or decay compromising the pulp chamber. Normally, bone levels in adjacent teeth are compromised too. Heavy deposits of calculus can be appreciated sometimes. Treatment of class 5 lesions. Smith in 2014 conducted a systematic review to evaluate the best available evidence regarding the treatment options and outcomes of periodontal endodontic lesions. Great heterogeneity exists among studies regarding applied treatment protocols. Treatment of combined endodontic-periodontal lesions includes periodontal and endodontic approaches with non-surgical and surgical methods. In all publications, a root canal treatment was performed as initial treatment. Two publications report the convenience of a two-step root canal treatment approach. After a variable in time reevaluation, in all publications but two, further periodontal therapy was applied. The conclusions are that there is not a clear treatment protocol established for the two combined endo-period lesions treatment. A sequential treatment with root canal treatment as first treatment step appears to be reasonable. A reasonable time for healing the endodontic lesion after root canal treatment is suggested to consider before periodontal therapy is applied. Abbott, in his paper from 2009 in the Australian Dental Journal, proposed that teeth with concurrent and communicating endodontic and periodontal diseases requires comprehensive treatment with both endo and period therapy. Ideally, the two diseases should be managed concurrently, although in a planned and sequenced stages to reduce possible complications from one disease entity affecting the outcome of the treatment of the other problem. Treatment starts with root canal treatment. A temporary root canal space of duration with a canal medication is applied. Authors proposes the use of a corticoid paste leather mix for 4 weeks and then a change in the canal medication for a 50-50 leather mix calcium hydroxide mix. In this stage, it is important to create an adequate non-leaking interim coronal restoration. At 4 weeks normally, non-surgical or surgical if needed because of the defect characteristic, scaling and root planning and oral hygiene instruction are applied. The concept is to apply the periodontal therapy while the root canals are still medicated, since this creates a better and favorable environment for bacterial survival. At the 3 months after periodontal therapy, the periodontal healing response should be reassessed. If response has been favorable, then endo and restorative treatments can be completed. Periodontal maintenance and periapical healing should be reevaluated in next appointments. Alternative, if the initial periodontal response has not been favorable or is not ideal, previous steps can be repeated. Prognosis of class 5 lesions. Prognosis in concurrent and communicating endodontic and periodontal diseases will initially be difficult to determine in most cases prior to treatment. It is essential to continually reassess the prognosis after appropriate time intervals to allow healing and stabilization of the tissue affected. Prognosis depends on primary cause of diseases, amount of attachment loss prior to treatment, and patient healing response and compliance. Britain evaluated the clinical, radiographic, and histologic outcomes of 3 different surgical protocols when treating induced apicomarginal perioendo bone defects in dogs. Treatment of combined induced perioendo lesions using the absorbable collagen membranes alone or in combination with an organic bovine bone matrix resulted in an increased amount of bone and periodontal ligament formation and significant increases in the amount of new cementum when compared to open flap debridement. Results from this study are supported by a number of case reports on the application of guide tissue regeneration techniques and periradicular surgery in teeth with apicomarginal defects. Cortellini in 2011 published a long-term randomized clinical trial to compare the clinical and patient-based outcomes following periodontal regeneration or extraction and replacement of hopeless teeth with chronic perioendo lesions and or attachment loss to or beyond the apex. This controlled clinical trial demonstrated that periodontal regenerative therapy can change the prognosis of clearly hopeless teeth due to the presence of deep infrabony pockets defects extending to or beyond the apex. Regeneration led to the retention of 92% of the hopeless teeth scheduled for extraction and improved their prognosis. Retained teeth had clinically stable periodontal parameters, comfort, and function for a 5-year period. Author remarks that these favorable outcomes can only be achieved by a careful, selected patient population, applying the state-of-the-art regenerative therapy by experienced clinicians and with a strict periodontal supportive care program. So, in conclusion, treatment decision-making and prognosis depend primarily on the diagnosis of the specific endodontic and or periodontal disease. The main factors to consider are pulp vitality and the type and extent of the periodontal defect. Diagnosis of primary endodontic disease and primary periodontal disease usually present no clinical difficulty. In primary endodontic disease, the pulp is infected and not vital. In primary periodontal disease, the pulp is vital and responsive to testing. Primary endodontic disease with secondary periodontal involvement, primary periodontal disease with secondary endodontic involvement, and true combined diseases are clinically and radiographically very dissimilar. Prognosis and treatment of each endodontic periodontal disease type varies. In true combined disease, there is a more worse prognosis than other types of endodontic periodontal problems. In general, assuming the endodontic therapy is adequate, what is of endodontic origin will heal. Thus, the prognosis of combined diseases rests with the efficacy of periodontal therapy. So, thank you very much for your attention, and remember, Barcelona is waiting for us. The Department of Endodontics from Universitat Internacional de Catalunya and the European Society of Endodontology are preparing a really great meeting next September in Barcelona. Hope to see you all there. Thank you very much.